started. So thank you all for being here. I think a lot of people will start trickling in as we get more into the panel discussion. So welcome. You are at the Prevention is Power, Taking Action for Health Equity event. So April is National Minority Health Month. So we have invited a group of analysts to come share with us about minority health. So the mission of the Office of Minority for this month is to really focus on a call to action. It's a change for all of us to unite towards a common goal of improving the health of our communities. So today's panel, we're really trying to focus on opportunity and what have been some successes in the community. And too often we do focus mainly on disparities and how all the hardships of the minority communities, but we really want to be looking at the future and where we have to go. So we have some fact sheets on the community health disparities. We just got all of the data updated, so it's 2015 data that's available if you want to take a look at those and those numbers. And then we also have the health disparities report. So the Office of Health Equity puts out this report every 4 years, and so the last one was the 2013 report, and that's available there too. And again, if you just came in, we have some other organizations have brought their pamphlets and information about their groups you can pick up too. So, so my name is Annie Guo, and I am with the Office of Health Equity, and I wanted to introduce Mauricio Palacio, the director of our office, to share a few things.
Thank you, Annie, and welcome everyone. Thank you to the panelists, and to everyone here tonight. And as Annie said, we're celebrating Minority Health Month, and actually 30 years ago, in 1985, Health and Human Services issued what is called a Heckler Report that was really highlighting disparities. And this was the beginning of really concerted efforts to address health disparities in the United States. So it's a milestone for us to commemorate, but also to advance and continue seizing opportunities to promote health equity and really diminish these health inequalities and call to action. We in the Office of Health Disparities, we're a small office, but there are, other than Annie Guo here, we have Annie Jones also works with the Office of Health Equity, and we have Maria Ayers, who does our language services program, and Deanna Butler with our evaluation and the health disparities grant program. Many of you may know her. But the mission of our office really is to align resources and priorities so we can improve and sustain health equity in Colorado. We're a conduit. We really like to link folks, organizations, communities, systems for everyone to bring their spheres of influence and impact the work of health equity, because one agency alone cannot do it. And we're going to hear about 4 different perspectives here from our different racial and ethnic communities, and also to engage in a dialogue here. I don't want to talk too much, but wanted to also tell you that in 2013, when the Health Disparities Report was issued, we modernized the office from being the Office of Health Disparities into the new Office of Health Equity that's more encompassing. It includes more communities, and it's been a wonderful opportunity and challenging work, but welcome again and enjoy today's meeting and dialogue. And we also coordinate the Health Equity Commission, and we have 2 commissioners here, Dr. Anita Mosley-Henry and Chris Armijo, who's our commission chair, and we also have our vice chair, Leo Katari. And the commission advises the department through the office on health equity issues, on workforce development, on data, and it's been a wonderful, wonderful group to help us promote health equity in the department and to bring that community perspective and other systems. We also have 2 other sister agencies as part of the commission, Health and Human Colorado Department of Human Services and Healthcare Policy and Finance. So thank you.
Thank you, Mauricio. So at this time, we wanted to go around the room and allow everyone to introduce themselves so we have an idea of where everyone's coming from. So we'll start.
I'm Jan Stapleman with Communications.
At the department.
Yes, at the department.
I'm Olga Gonzalez. I'm a community member, and I've written curriculums and created programs moving health
Smith, and I'm the Fiscal Compliance Manager, Managed Services Division here at the department.
I'm Angela Simmons. I'm also with fiscal contracting, with compliance and operations here at the department.
I'm Lisa Barrick-Dawes, and I'm with the Association for all the local public health departments in Colorado.
And I'm Rita Beam, and I'm Perinatal Nurse Manager at Tri-County Health Department.
And I'm Leo Guattari, the Health Policy Manager for One Colorado, an LGBT advocacy organization.
Jim Davidson, Public Health and Environment, Human Resources Manager.
Crystal Garcia, Colorado Department of Public Health and Environment, Prevention Services Division.
Hi, I'm Monica Molina. I'm the Viral Hepatitis Program here at CPP.
And I'm Amy Warner, and I'm with her, the Viral Hepatitis Program.
I'm Dara Burris, and I'm a fellow in environmental deputy and occupational health programs.
Tom Simmons, I'm also here at the department. I work in environmental.
Marissa Vasquez, I work at Denver Public Health, Youth Sexual Health.
Mary Moran. I work here at the Department and Recruitment Contracts. I'm Phil Vaughn, and I work here at the department with Vital Records doing birth registry.
I'm Chris McCracken. I work here at the department in PST.
Patty Usaki. I'm with a community group, maybe Neighborhood Health Department, as well as on the mayor's Sustainable Food Policy Council.
Lorraine Dixon-Jones. I'm a policy analyst here at the department.
Hi, I'm Sarah Hernandez. Work here at the department as an evaluator and a center for environmental data. My name is Leah Anderson, and I work here at the department
And that's Pender.
Nadine, we're just introducing ourselves.
My name is Nadine. First of all, I apologize for being late. And I'm a state board of health member as well as a member of the Mountain States Regional Health Equity Council.
And then Mia.
Hi, my name is Neil. I work in the governor's office.
Great, thank you. So, Rosemary? Oh. Oh, I think she did.
Oh, I didn't hear you, Rosemary, sorry.
So just want to share that the panel in this event will be recorded. So there's been a lot of people who aren't able to attend and have asked us to post it. So if you know of anyone that would like to see the presentations later, you can share that. So to give some context, so each of the panelists were asked 3 questions to set the stage, but those are, what are the disparities and inequities that are prevalent in your field or in your community? What are the tangible opportunities and solutions to these inequities? And then how can health equity practitioners and advocates take action on these issues? So I will not read everyone's bios, but they are printed and available in the back. But we are going to start now with Nita Mosby Henry. She is the Senior Vice President of Human Resources and the Chief Inclusion Officer at the Children's Hospital of Colorado. So let's welcome Nita.
So I'll start out my comments by saying, contrary to popular belief, I am not the spokesperson for the Black community. So you will not hear those words of wisdom from me today. Likely the thing that I will say about the Black community is we continue to prevail in being #1 in health disparities across almost anything that we study. And that in and of itself is problematic. I don't want to spend my time reinforcing that because I'm sure everybody in the room already knows that. What I'd like to talk about really is the context I think we all should be thinking about as we talk about what this health equity conversation is all about. So I oftentimes, when I'm talking about health equity, will talk about our need to go backwards in time a bit to think about how we got here in this topic of diversity. The fact that we're talking about minority health is important, but the other part that's important about that conversation is we think about what this word diversity has meant to us historically anyhow. So if you think about where we've been over the past decades with where diversity even came from, there have been so many iterations of reasoning around why we got diverse in the first place. We didn't accidentally get diverse. In many cases, we were getting diverse to right a wrong. In some cases, we were getting diverse because organizations or systems were smart enough to know that richness and diversity is what makes the organization or the system better. So we've been all over the map about how we got diverse. In some cases, the diversity was institutionalized in systems, in organizations, and that's a good thing. And in some cases, diversity never got institutionalized. And I think it's important for us to think about that. The lack of institutionalizing diversity is, in fact, the source of why we're talking about inequity, health inequity, and disparities today. I really do believe that institutionalizing things is what creates solutions in some case to what we're after right now. So we haven't institutionalized diversity. Here we are in 2015, and there are lots of organizations that still have not reconciled why diversity would be important. The other thing that we should be thinking about around what we need to be institutionalizing is even in organizations that have done great work, organizations and systems that have done great work with contemplating what diversity should look like, we then have not properly broached what you do with the diversity once you have it. And so when you don't know what to do with the diversity once you have it, you don't know how to leverage it, you don't actually know what it means, you've not linked it at all to your outcomes and your outputs, you might as well not be diverse in the first place. So this whole topic of inclusion is where I'm headed now. And we've not had the conversations about inclusion either in our systems and in our organizations. And so I'm not painting a bad story here, I'm actually painting a good one, bear with me. If we've not institutionalized diversity in a systematic kind of a way, and we certainly have not even broached the topic of inclusion in a systematic way, then having the conversation about how to end inequity in health, almost impossible. So my thought is, this is a musing from Vita that you'll get now. My thought is, until we focus on institutionalizing diversity in our systems, we're talking heads. We are absolute talking heads. So I want you to think about this for a minute. I want you to think about our city system, city government. There's 10,000 employees there. In the state system, over 30,000. If you pick a hospital, there's 15,000 or more employees in hospital systems. Pick our school system to start counting people. We are talking about entire communities sitting in organizations right now where we haven't even institutionalized diversity. And so talk about impacting a literal community. It would start if we just impacted organizations that we have actually more control over. So if I can be vulnerable with you for just a minute, before I went to Children's, I was the head of human resources for the city and county of Denver. And when I looked at that population, it was 10,000 employees in that population. And what I did first is I looked at the entire 10,000 as if it were a community. Every city agency reflected a neighborhood to me. There were lots of socioeconomic considerations within that population. There were wage gaps, there were education gaps. I can tell you right now, if we could solve that within our organizations, then we have the answer for how we would solve it in our communities. So when I looked at my employee base and I saw that we had a population of people that did not have their high school diplomas yet, that meant something to me. It meant something to their income. It meant something to their attendance. It meant something about their ability to thrive in the organization, and I guarantee the system that those very same considerations would be true when they left work and they got home. So I believe that the influence that we could make, that we're ignoring, is within our systems, our work systems. If we could just leverage it there, because the people that work in the work systems are the community. Imagine that. Why do we continue to look at the community as something separate than the employer groups? They're the same. It's the same people. It's the same body. And what a way to influence. So when I think about the work that this department has done around the social determinants of health, why is that an overlay for the community? Why is that not an overlay within the employer groups? Why aren't we looking at these very large workforces and saying, I'm going to plot the social determinants of health model right on it, and I'm going to start to map people in that way and influence their lives in that way, and imagine the viability of a model like that. So my commitment in the organizations that I've been a part of and the organization that I'm a part of right now, and my commitment to community, is they're not that different. They're not that far apart. And so it's not good enough for me anymore to say, oh, it's so hard to get these things done in community when I haven't done those things inside of the organization that I do have some direct control over. I would love for us to shift our thinking and the way in which we contemplate how to end equity issues in community, and I think it's right at our fingertips and we've just sidestepped it. So hopefully I can talk a little bit more about that as we sort of go through the panel on ways in which that can happen within systems that are really simple, at our fingertips, and in many cases free. One of them I'll just share, and I promise I'll just pass this on. One of them is, why don't we know where our employees live? Why aren't we GIS mapping our employees by zip code so that you have a map of where everyone lives? So I did that at Children's, and I can tell you who lives in a food desert because I know by their zip code. And not only do they live in a food desert, I can tell you what that means to them at work. I can tell you that there's something socioeconomic tied to that. I can tell you all of that about my employee base, and now we're poised to do something about it. It's that simple. It was free. All of that data was already in the HR system. I just needed to map it. That's the kind of stuff we should be doing now. This is 2015, and we've got to be more progressive about how we look at disparity and at what point are we looking at it. If we're waiting for it to land in the community before we start studying it, then I would argue that we're way too late. We should be looking at the workplaces.
Great, so we just wanted to ask, can everyone hear in the back? Okay, because we can get a microphone, and then the baby can come back in. Do you want to try it?